Right, so I'm going to talk about treatment options. I guess I want to kind of give you a flavour of things. I'm absolutely not expecting people to go away with all of this information in their heads, but it's just to give you a bit of a flavour of what's available. And obviously in terms of actual treatment discussions, you have those with your own consultant and team and sort of talk through what's right for you, but give you a bit of an idea of what's available and exactly what those options tend to involve. So we'll talk about what drugs we have available, how do we choose, and a bit about the practicality, side effects, what you might expect if you're going through treatment. So first of all, what drugs do we have available? Well, chemotherapy, we'll skip straight over that. Monoclonal antibodies, that's one treatment option we have. We'll talk a little bit more about what these things mean as we go on. BTK inhibitors and BCL2 inhibitors. And straight away, we'll rule out the chemotherapy bit, because as I've said, that's not something we use anymore in CLL. Why don't we use chemotherapy anymore? And I've just put a little box at the top to kind of explain what we're talking about when we mention chemotherapy. We're talking about the kind of drugs like fludarabine and cyclophosphamide that Bethan mentioned she'd had, chlorambucil, bendamustine. These are all kind of chemotherapy treatments that you might have heard of, which we used to use in CLL, but no longer. Well, we don't use them because they're not targeted, quite literally a hammer to crack a nut. So we wipe out all of the blood cells in the bone marrow in order to wipe out the CLL cells. And they come with a lot of side effects, particularly affecting, because they're a hammer to crack a nut, all of the normal healthy blood cells at the same time as affecting the CLL cells. And so that meant that things like admissions with low neutrophil white blood cell counts and therefore being predisposed to getting bacterial type infections were common for patients going through this treatment. Patients often needed transfusions to support their red blood cells or the platelet cells because the chemotherapy had wiped those out. People lost their hair, and I've written general chemo grottiness. So generally feeling a bit crap as they went through their treatment. And for some people, the bone marrow would take months or even years to recover. So those low blood counts could remain low for months or even years after treatment finished. And most importantly, the newer agents that we have available to us are actually more effective. So it's not just the bad side of chemotherapy, it's actually that the new stuff we've got is better at doing its job. And we can see that now. There's a lot of stuff now around with CLL that for a good number of patients with CLL now, with the modern treatments that we have available to us, that the survival of patients will be akin to if they had never had CLL, because the treatments we have available will keep them alive for as long as if they'd never been diagnosed with CLL in the first place. And I've got two studies here to show that, and I'm just going to pick out the important bits of this. So this is a study called Elevate-TN, and it's got acalabrutinib as one of the novel agents in it. But the things to pick out here, so first of all, the median age of patients going into this trial was 70. And if we looked at the people who got acalabrutinib, so a treatment that we have available to us right now in the UK, 5 years from starting the treatment, 84% of these people were alive. If we look at the UK life tables for the same sort of time period when this study, around about the time this study was being done, if you were 70 years old, the chance of being alive 5 years later was 85%. So virtually the same as if you had CLL and were on treatment. And similarly, another one of our main sort of contenders, one of our novel treatments, this is a study CLL14, which included venetoclax and obinutuzumab. And we'll talk about these treatments more as we go on. But again, median age 72 of the people in this study. If you had venetoclax and obinutuzumab, the 5-year overall survival rate, 82%. If you looked at the UK life tables for the same sort of time period, 5-year survival, 84% for 72-year-olds. So essentially we're looking at virtually the same life expectancy for people with CLL having treatment. Just to point out here, this is a chemotherapy, chlorambucil. You'll see here the life expectancy not as good as the sort of other life tables. Similarly here we've got chlorambucil and other chemotherapy. So you can see that the novel agents are really improving life expectancy, okay? How have we got to actually using these novel agents? Well, really understanding the disease of CLL and the biology of CLL has been key. And that's not to say that we understand everything about CLL, very far from it. But essentially, some really key information in terms of how CLL cells kind of maintain themselves, how they stay alive, how they avoid being, killed off by the body has been really key. So understanding how the signaling goes on, how messages get sent through a CLL cell that keeps them alive. And that involves something, a protein called BTK, So the treatments we use are BTK inhibitors, and also this important protein BCL2, and we use BCL2 inhibitors, okay? So it's about understanding the biology of CLL, which has led to the development of these much more targeted treatments. So just to give you some names, and I'm sure many of you will have heard of these already, but just to give you some names. So the treatments we currently have available right now, so BTK inhibitors, these are tablets, easy to take. So ibrutinib was the first generation BTK inhibitor, and we've actually got second generation BTK inhibitors now, acalabrutinib and zanubrutinib, and typically we would tend to use the second generation ones where we have them available. I've put in brackets at the bottom because we don't yet have pirtobrutinib available, but this is a sort of next generation BTK inhibitor, which at the minute we don't have available on the NHS. It can be accessed through other routes, but such as compassionate access schemes. We hope to have access to pirtobrutinib in the NHS probably quite soon, but we don't have it available currently. BCL2 inhibitors, again, these are tablets. And we basically have one main contender in the BCL2 inhibitor section called venetoclax. There is another one called sonrotoclax, which is a sort of next generation updated version of venetoclax. That's currently only available in clinical trials, so we're quite a long way away from having access to that in the NHS. Tablets taken at home. Monoclonal antibodies. Now, these aren't actually novel agents. We've had monoclonal antibodies around for quite a lot of years. The first one was rituximab, and it used to be taken alongside chemotherapies, such as fludarabine and cyclophosphamide, in this combination called FCR. So monoclonal antibodies aren't new. Monoclonal antibodies aren't actually chemotherapy. They are antibody treatments. They're not only used in the treatment of cancers. They're actually also used in things like rheumatoid arthritis. So there's a lot of different uses for monoclonal antibodies. They're not a chemotherapy, but they're an antibody treatment which targets one of those cell surface markers on the CLL cells, which identify them as CLL cells. So we know that they're a very useful treatment as part of CLL. And there's rituximab, and then there's this updated version called obinutuzumab. These are infusions. So these come with a degree of inconvenience because you have to have these in hospital on a day unit as a drip, okay? So tablets on the left, and then we have these monoclonal antibodies, which are infusions. So how do we choose which treatment for which patient? And the absolute key message, and honestly, if the only thing you remember from this whole treatment talk is this, I would say there is no right or wrong answer, okay? There is no absolute that says this patient would do best with this and this patient would do best with this. There is no right or wrong answer. And this is why it really is a conversation with patients when it comes to choosing treatments, because things that are important to you and your lifestyle are really key about what treatment might fit you best. All of the treatments come with pros and cons, and all of them are good options. And just to hammer home the point, there is no right or wrong answer, okay, in terms of which treatment we choose. In very broad terms, we can divide CLL treatments up into fixed duration or continuous. Fixed duration, you have the treatment for a period of time, 1 to 2 years, and then it stops. Continuous treatment, you start taking the treatment and you keep taking it for as long as it's working. At some point in the future, it will stop working, at which point we need a different treatment. Or if you had side effects such that you couldn't stay on that treatment because you were getting side effects. That's much less common, but it does happen. So fixed, you take it for a time and then it stops. Continuous, you start taking it and you keep taking it indefinitely until it doesn't work anymore. I'm always amazed by how completely different patients are, because some patients say, definitely fixed duration for me, please. I want to get it over and done with and then I want to forget about this. And other patients say the exact opposite. I feel better if I take a tablet every day. I'd rather take something continuously, so please can I have that continuous one because it makes me feel reassured because I'm taking a tablet every day to keep it under control. So you will potentially have an opinion on which of those boxes you fit into, and everybody is different. And that's one of the really key things in terms of making this treatment decision. Okay, one of the things we kind of put into the mix when we're making a treatment decision. So if we talk about a patient who's never had treatment before, okay, what are our options right now? So we can either have continuous, which is a tablet. So it's one of these BTK inhibitors. So I've put ibrutinib in small letters because that's the sort of old version. We now tend to use acalabrutinib and zanubrutinib. Tablets that you take continuously, indefinitely. Or fixed duration, it starts and it stops. And here we've got two options. One of them, and you'll notice that both of them include venetoclax. Okay, so fixed duration always includes venetoclax. We can either have the top one, which is venetoclax with a monoclonal antibody, so there's that bit of inconvenience because it means you need to come in for the infusions. Or you can have ibrutinib and venetoclax together. Well, that's 2 tablets. You don't need to come in for any infusions. So I'm going to talk a little bit, first of all, about BTK inhibitors, so one of our tablet options. This is the one that is, you start taking it, you take it continuously. Again, ibrutinib in brackets, because it's the sort of first generation. Acalabrutinib and zanubrutinib are the more updated versions. These are generally very well tolerated. It's a tablet that you're either taking once or twice a day at home. Generally, when you first start the treatment, I would want to see you in clinic, probably if you started, I would want to see a fortnight later, and then probably a fortnight after that, and then if all is well, maybe a month after that, and maybe a month after that, and then we start spreading it out. And so we have patients who are on these tablets who only come to clinic or even do a phone consultation every 3 or 4 months. So this can be super convenient in terms of not that many trips into hospital. A really key thing that we always say to patients, because otherwise it can feel very worrying, is when you start one of these tablets, let's say your white count is already high because you've got leukemia and that's part of what we're seeing in your blood count. Obviously, if you've got SLL, we won't be seeing it in the blood, we'll just be seeing it in the lymph glands. When we first start any of these treatments, it seems to target the lymph glands first. So all the leukemia cells come out of the lymph glands, so people very quickly notice the lymph glands have gone, but their white count in their blood goes up. Oh my God, my white count's going up, the treatment isn't working, it's doing something bad. It's just part of how it works. Comes out the lymph glands first into the blood, the white count in the blood goes up, and then over a period of time it comes down. Okay, so that's something we just always warn people because otherwise that can seem quite alarming. So, I'm just going to show you a little bit of data. I'm not going to get carried away with graphs and things, but just to show you that, this is where the evidence for acalabrutinib, one of our BTK inhibitors, comes from. This is called the Elevate TN study. Quite honestly, it took me months to work out that TN stood for treatment naive in this study. So patients who've never had any treatment before. And essentially here, what we're randomizing in these 2 bits here is something with acalabrutinib in it. And I'm going to concentrate on this maroony one in the middle, acalabrutinib on its own, versus this one down here, which has got chlorambucil chemotherapy in it. So patients were randomized to one of these options, chemotherapy versus acalabrutinib. And if you concentrate on this maroony arm here, which is the acalabrutinib, compared to this chemotherapy arm down here, you can see immediately a huge difference in terms of the number of people as time goes on whose CLL remains in remission. It has not progressed, it's not come back, it remains in remission. And so I think it's nice to have a vague number in my head. You could take away from this that if you start somebody on acalabrutinib, after 6 years, 2/3 of those patients are still in remission, still taking the tablet. Still in remission, still not seeing sign of the CLL becoming active again. Bear in mind as a patient, that means that after 6 years, you're still taking this tablet. That's what we mean when we say continuous. You started it 6 years ago and you're still taking it and you're still in remission, well, you're going to keep taking it, okay? Now, we've talked a little bit about this IGVH business. We talk about IGVH being mutated, those B cells that have progressed through the lymph node, the germinal centrum, become a little bit more mature when they turn into the CLL cells, or the ones that haven't got there yet that are still at the less mature end that we call unmutated. So unmutated versus mutated. I don't know if you remember my graph that I showed you earlier, but I showed you a graph with 2 lines on it that very clearly said if you had unmutated and you were being treated with chemotherapy, that those lines were a long way apart. If you had unmutated CLL, clearly your CLL was progressing, relapsing, coming back more sooner than if you had mutated CLL. If you concentrate on these 2 maroon lines here, these are patients all being treated with acalabrutinib, and some of them are mutated and some of them are unmutated. The dotted line is the mutated and the solid line is the unmutated. And you can see that basically those lines are very close together, and in places they're even crossing. And there's no statistical difference, but statistically significant difference between these 2 lines. So essentially we could say that at 6 years, 2/3 of these patients, whether they had mutated or unmutated IGHV, are still progression-free. So it looks as if this unmutated IGHV problem, which was such a problem with chemotherapy, doesn't have such an impact on the outcome of treatment when we look at these novel treatments. Similarly, and so here we're looking at zanubrutinib, so another sort of updated BTK inhibitor. This is a study called the Sequoia trial. And this is an arm, so a group of patients in the Sequoia study who specifically were selected because they had a p53 deletion or a deletion of 17p, so that short arm of the 17 chromosome chopped off and therefore P53 genes been lost, okay? So somebody we would consider high risk in the era of chemotherapy. I showed you a chart earlier that looked awful, where the yellow line on the left-hand side was, really disappearing off very quickly. Those patients were progressing very quickly in the era of chemotherapy. Well, here, when they specifically selected out those patients and treated them with this zanubrutinib, 70% of patients at 5 years are still progression-free, i.e. they're still in remission. The zanubrutinib is still keeping control of their CLL, okay? So a huge difference in terms of what we're seeing with these novel agents compared to the chemotherapy that we had before. So what are the pros and cons? Because, it looks to me like, looking at this, well, why don't we all just go on a BTK inhibitor? It looks amazing, even for people with high-risk features, so why don't we just stick everybody on that? Well, there are pros and cons. So the pros, they're easy to take because they're just tablets. There's no infusions involved, so you don't have to come for trips to the day unit for an infusion of a monoclonal antibody. As you can see, they seem to be especially useful when there are these high-risk features, unmutated IGHV gene or the P53 problem, either deletion or mutation. And as I've said, all patients are different, but some patients like to be on a tablet continuously because they find it reassuring. In the con side, if we go straight to the bottom of the list, some patients want their treatment to be over and done with, so they might not like this because it's continuous. If we go back up to the top, and this, I guess, is one of the things we think about when we're using any continuous treatment for anybody, is if you're on a continuous treatment, it means you're being exposed to the side effects of that treatment indefinitely. So when we think about the side effects of a BTK inhibitor, in particular, the main things that stick in our head that we warn you about and ask you about, one is hypertension, which is high blood pressure. One is heart arrhythmias, in particular atrial fibrillation. If I took 100 people off the street of a median age of 60 or 70, if we're saying that's the median age of a CLL patient, and checked all of them, 2 or 3 of those people would have atrial fibrillation anyway. They don't have CLL, they're not on any treatment, they would have atrial fibrillation. Atrial fibrillation is an irregular heart rhythm. If we give those 100 people zanubrutinib or acalabrutinib, that rate goes up maybe to somewhere between 6 and 10 people out of 100. So it's not a huge increase. We're not saying that the majority of people will get a heart arrhythmia, but it does increase the risk of it compared to somebody not on the treatment. So it's something we need to look out for. And the other side effect we're aware of is bleeding or bruising. So some of these, it's a little bit like being on something like aspirin. If you're on aspirin for a heart condition or something like that, that can make people a little bit more bleedy or bruisey, and similarly these tablets can do the same. Now, if you're taking one of these tablets and it's continuous and indefinite, and as you saw, 2/3 of people will still be on them after 6 years and they'll just keep taking them, well, that means you're getting exposed to those side effects for all of that time and beyond. So things like blood pressure, that's really important because we all know, regardless of CLL, that having high blood pressure puts you at risk of other things, strokes, heart attacks, and so on. So it just means that we are exposing you to a side effect which might cause you other problems for a prolonged, indefinite period of time. Okay, so it's something we have to think about. And you don't get a treatment-free period, because if you stay on this tablet until it stops working, then at the time that it stops working, we're going to need to put you on something else for your CLL, if the CLL needs treatment at that point. So it means that from when you start this tablet, you're kind of on a treatment indefinitely. Okay. Another thing just to mention about BTK inhibitors, and this is kind of out of interest really, because I don't think in clinical terms, in terms of how this impacts you, that this actually has a big effect. What we see with BTK inhibitors is they don't seem to achieve as deep remissions when we use continuous BTK inhibitors. So what that means is if we were to measure in your blood or your bone marrow at a really, really, really super sensitive level, are there any CLL cells left there at all? We will often find, we're not seeing any active CLL going on. The blood count's gone to normal. All the lymph glands have gone away. You feel really well. But we can still detect a very low level of CLL that's still just there in the background. That's very common on this kind of treatment. So we can't say that we've achieved a deep remission. We can say we've achieved what we call a complete remission, but not a deep remission, which we sometimes refer to as MRD, or minimal residual disease, a very, very sensitive extra test in terms of the level of remission. Does it matter? That's a rhetorical question, genuinely, because, does it matter that we haven't achieved this super deep remission if we've actually still achieved 2/3 of patients 6 years on are very well with normal blood counts, no lymph nodes, feeling very well? So, moving on from those continuous BTK inhibitors to fixed duration, I said if we were talking about fixed duration, then there was definitely going to be some venetoclax tablets involved. This is just a little outline of the study from when we sort of got access, or venetoclax was licensed for us to be allowed to use it in this way. So this is 12 months altogether, so a year of treatment. First of all, 6 cycles of venetoclax tablets, given alongside 6 months of obinutuzumab monoclonal antibody infusion. So a bit less convenient because you've got to come in and have those infusions in the hospital. And again, this was compared to something containing chlorambucil, so a chemotherapy kind of comparison, okay? And again, you can immediately see, because this is the venetoclax obinutuzumab line, the blue one, very clear that patients their CLL is remaining progression-free, i.e. it's not relapsing or becoming back much longer than the patients treated with chlorambucil chemotherapy type treatment. So we could say here that roughly 53% of patients at 6 years are progression-free, or 6 years after starting treatment, half of patients will still be in remission with this treatment. When we use venetoclax obinutuzumab, or anything with venetoclax in it, you might have heard or read about tumor lysis. That's something we have to be very careful of when we're using venetoclax. What that means is if we give a treatment, whatever it is, whatever this cytotoxic, killing off cells treatment is, and it's attacking the CLL cells, those cells will release potassium. They release phosphorus, or phosphate, which binds to calcium, so you get a high phosphate level and a low calcium level and a high potassium level, and they increase these levels of uric acid. The key thing here, the thing we worry about if you're at risk of tumor lysis, is having a high potassium level can upset your heart. So that's why we care about this and need to measure for it and know about it and do something about it if it happens, okay? So tumor lysis is something we have to bear in mind if somebody's starting venetoclax-based treatment. And it's most likely to happen if you're starting the treatment when you've got a high white blood cell count or you've got big chunky lymph glands or a big spleen, just because there's a lot of cells there for the venetoclax to go in and work on all at once. Because venetoclax tends to clear things out quite quickly, both in the blood first of all and in the bone marrow, and then sort of later on in the nodes as well. So it tends to have quite a rapid effect, and therefore we have this risk of all these cells breaking down very quickly and causing this increase in potassium. We can manage this, okay? So we can avoid and manage this very safely as long as we've got the right strategies in place, which basically means thinking about it before you start the treatment, noticing, right, you've got a high white count or you've got big chunky lymph nodes, you're somebody at risk of tumor lysis. Therefore, we want you to drink plenty to flush your kidneys through. We might even give you a drip of fluid to flush your kidneys through, and we're going to give you these tablets or this injection to protect your kidneys and sort out these potassium and salt and acid levels in your blood as you start the treatment, okay? So this is very manageable as long as we think about it and are looking out and using the right strategies. Another thing, and I said that when we're using venetoclax alongside obinutuzumab, and we can also use it alongside rituximab, is infusion-related reactions. So that bit of inconvenience with the monoclonal antibodies is you have to come and sit in the hospital to have them, and we have to give them very slowly. Everybody's different. Very slowly might mean 4 hours for some people. It might mean 8, 10, 24 hours for somebody else. So sometimes you even have to stay overnight, okay? And this is because infusion-related reactions are very common. Probably at least a quarter of patients with rituximab, maybe a third or even a half of patients with obinutuzumab will have some kind of reaction. It happens while you're physically sat there in the hospital with the drip in your arm, with the infusion dripping in. It's not something that's going to happen to you after you've got home later on. Typically, the most common thing is things like shakes or shivers or a fever. Some people will feel breathless or get a rash. Some people will have a feeling of impending doom. Oh my God, what are you doing to me? I feel horrendous. Exceptionally rare is anaphylaxis. Okay, that is exceptionally rare, but obviously that's a very serious allergic type reaction. Our nurses on the day units give these treatments all the time. So this is something obviously that we're watching very carefully. It's why the treatment is given very, very slowly, and your temperature, blood pressure, oxygen levels, etc., monitored very frequently all the way through the treatment, so that any signs of an infusion-related reaction we can, know about it and act on it. But as I say, it's manageable as long as we're looking for it and managing it as it happens. That can mean slowing the treatment right down, even stopping it for a period of time. We've had patients who've had to stay overnight for 24 hours or more to get the drip in, okay, because they have a reaction to it. So pros and cons of fixed duration venetoclax and monoclonal antibody. Well, I'll go for the cons first. You have to come in for those monoclonal antibody infusions. So that does mean time in a day unit. in the hospital having those infusions. And I once worked out, I think it was something like 14 appointments in the first 5 weeks if you're having venetoclax and obinutuzumab in order to get the infusions and have all the relevant blood tests to be monitoring for tumour lysis, so to be monitoring for those potassium and calcium and phosphate levels at the right time. So it's a lot of trips into hospital in that first 5 weeks. Hopefully for the vast majority of patients that's all as an outpatient, but it is a lot of trips into hospital. And I always say to patients starting venetoclax and obinutuzumab, the first few weeks are a roller coaster, because almost inevitably what happens is we give you a load of appointments, you're going to come in on these days and have these blood tests, you'll have your infusion on this day, and pretty much on day one something happens, like you have a reaction, you have an infusion reaction, we have to say, we're going to have to do this slightly differently now, we're going to do your infusion much more slowly, and we're going to break it up over a few more days rather than the one day that we set, all of these kind of things. So we start with a plan and then it changes, like on day 2. Okay, so it's often a bit of a roller coaster in those first few weeks. In terms of side effects, a lot of patients who are on venetoclax say they just have a little bit of a queasy tummy and sickness. It's rare for this to be a really major problem, something that really impacts on quality of life in terms of affecting what people can do from day to day. But it definitely is a thing. People definitely tell us that they just feel a bit sicky, a bit queasy, they need to take an anti-sickness. Some people get around it by taking the venetoclax tablet at night time. Usually it is manageable. The vast majority of cases it is manageable, but it is a thing that people say. And sometimes, and you'll remember from my slide earlier about the different healthy blood cells, it's quite common for us to see low neutrophil counts, so the low healthy white blood cells which help fight against bacterial infection, quite low, to get a little bit of low neutrophils, neutropenia when you're on venetoclax. Nothing like at the low level we see when people are having full-on chemotherapy. So not like that, but we tend to see like maybe a bit of moderate neutropenia, which is usually very manageable. If we look at the pros, some patients prefer fixed duration, it's going to be done and dusted and then I can forget about it. So this is all over and done within a year. And therefore the side effects, there may be a bit of queasiness, the low blood counts and so on, is over after that year. So we're not continuously exposing you to side effects indefinitely. We've got some evidence that if you've had venetoclax before, if it works for a good period of time, a number of years, we can use it again. So we can reuse the same treatment option again. And different to what I said with the BTK inhibitors, you remember I said that those, we don't seem to see this very deep remission, whereas we do seem to see very deep remissions with venetoclax-based treatments. However, if we look at how long they keep the CLL under control in terms of when does it come back in the future and you might need treatment again in the future, the time period is actually very similar, which is why I say, does it matter with the BTK inhibitors whether we get those very deep remissions or not? Some patients do especially well with venetoclax and obinutuzumab. So coming back to our IGHV business, you remember we said that the mutated IGHV in the era of chemotherapy seemed to have better outcomes. With venetoclax and obinutuzumab, we see that over 70% of patients are progression-free at 6 years, compared to probably around about 50% with unmutated IGHV. So this is different to the BTK inhibitors, because there, when I showed you these curves, they overlapped pretty much. You know, whether you had unmutated or mutated didn't seem to make a difference on how long your continuous BTK inhibitor kept control of your CLL. Whereas probably here with venetoclax and obinutuzumab, yes, the unmutated IGHV is still having an impact. Patients with unmutated IGHV are still relapsing sooner than those with mutated IGHV if they have venetoclax and obinutuzumab. However, 50% are still in remission at 5 years. That's a hell of a lot better than we used to have with chemotherapy. And it comes with all the pros of being fixed duration and so on. So there's no absolute right or wrong here as to what's the right treatment, but something that kind of, plays into our decision making. So where does that leave us? Very, very, very loosely, it might make us think, well, mutated IGHV, we've seen that those patients really do especially well with fixed duration venetoclax and obinutuzumab. So maybe we should prefer that in those patients. It avoids them being on a continuous tablet, a continuous BTK inhibitor, with those side effects continuously and with no treatment-free period. But if a patient told me, yeah, but I can't fit it in around my work, or I just cannot bear to come into the hospital that many times for those infusions, I really don't want that, I'm not going to say it's the right treatment, you have to have it. Fine. It sounds that for you, the continuous BTKI is the better option. Similarly, for unmutated IGHV or deletion 17p or p53 mutations, what we would have considered as poor risk genetically. The continuous BTKI treatment, so that acalabrutinib or zanubrutinib, seems to overcome the negative impact of those genetic high-risk features. So we might well prefer in those patients continuous BTKI treatment. But again, if somebody said, I'm worried about the bleeding risk because I had a bleeding gastric ulcer 5 years ago and I nearly bled to death on the floor, or I've got these heart problems and so I don't want to be at risk of high blood pressure or heart arrhythmias, venetoclax obinutuzumab fixed duration is not the wrong treatment for those patients. We've seen that 50% of them will still be in remission 5 years after having that treatment. So there is no right or wrong here. It really is thinking about all the different options. So if you should need treatment and your doctor seems to be asking you your opinion, it's not because we don't know the answers. It is because we don't know the answers, because we don't know the right answer for you without getting some of your thoughts about what fits in with your life or what other things are going on in your life that might be relevant to this decision. So we absolutely do take into account the CLL genetic risk factors, things like P53 and IGVH status. We absolutely need to think about your preference in terms of fixed duration suits me much better, or fixed duration is an absolute no because I cannot come into hospital for all those infusions, or patient factors, things to do that might mean that you're at a higher risk of bleeding, which might make us wonder about the BTK inhibitors, whether that's a sensible option. Heart history, do we need to think about the BTK inhibitors? Significant kidney problems. We worry about the tumoritis impacting on the kidney, maybe that makes the venetoclax option more difficult, and so on, other medications that might interact with the two. So there's a lot of different things coming into play here, which is why I say there is no right or wrong answer. It really is a sort of, treatment discussion, patient-centered treatment discussion about what to go for. Why don't we just put the two together? Venetoclax and BTKIs are such great treatments. Why don't we stick the two together? Well, we do have some great data about this now. So using these fixed durations, there's a lot of pros here. If we put venetoclax together with ibrutinib tablets, BTK inhibitors, all tablets, no infusions in hospital, and fixed duration, it's only 15 months, so we've got a lot of pros here. When we use it in that way, we have 3 months of ibrutinib. You remember I said that those ibrutinib or BTK inhibitors tend to clear out the lymph nodes first, so it tends to reduce the chunky lymph nodes, which reduces the tumor lysis risk by the time we start the venetoclax bit. So you get 3 months of the BTK inhibitor, and then 12 months of the two in combination. A lot to think about here. So does this treatment work better than any of the treatments we've talked about already? What about the side effects when we put the two of these together? And are you putting all your eggs in one basket? What about what happens when the CLL comes back later if you've already used both of these drugs up? So we've got great data about I plus V, so ibrutinib BTK inhibitor in combination with venetoclax. So one study called the GLOW study, the median age of patients here was 71. And again, comparing with a chlorambucil-based treatment, so chemotherapy-based treatment versus ibrutinib and venetoclax in combination for 15 months in total. Again, just as we've seen with all the graphs we've looked at, the patients who had chemotherapy were relapsing much sooner than the patients having ibrutinib and venetoclax. So we can see here 2/3 of patients at this 54 months, a kind of 4.5-year mark, 2/3 of patients are still in remission when they take I plus V, ibrutinib and venetoclax tablets together. There was another study running almost simultaneously called the Captivate study. The key thing to point out here is that these patients were about 10 years younger. So the median age in the Captivate study was 60, so just a slightly younger cohort of patients in that study. There they saw the same sort of progression at the same time point, 54 months, 4.5 years, a progression-free survival of around 70%. What about if we split up into these mutated versus unmutated IGHV business? Interesting. When we give this ibrutinib fixed duration with the venetoclax stopping at 15 months, the unmutated seems to be having an adverse impact again, because those curves, these top two red ones, mutated versus unmutated, in patients all taking ibrutinib and venetoclax, they're not overlapping. There's a definite separation. The patients with unmutated IGHV are definitely relapsing sooner. So this is telling us that maybe when we shorten the duration of the treatment, maybe it's not as effective as the patients who are on continuous treatment when we're dealing with the high-risk features such as unmutated IGHV. Side effects. The key thing here, we've already mentioned some of those heart and blood pressure related side effects with a continuous BTK inhibitor, and that's really key when we put it in combination with venetoclax. We do see a bit more neutropenia, low white blood cells causing risk of infections, and we definitely see more heart arrhythmia risks and problems. And in fact, in that GLOW study, which was older patients, there were even some sudden deaths due to heart arrhythmias. So that's absolutely vital that we think about that when we're assessing a patient. They didn't see the same level of significant cardiac arrhythmias in that Captivate study where I told you the patients were 10 years younger. So maybe it is something about the patients who'd gone on to the treatment and really looking carefully for any heart-related risk factors when you're thinking about this as a treatment option. Really importantly, in the "are you putting all your eggs in one basket" question, now we don't have hundreds of patients to look at here, but when we look at smaller numbers of patients, we know that patients who've been treated with I+V, who've then gone on to relapse in the future, have been successfully treated either with a BTK inhibitor or venetoclax again in the future. So it doesn't look as if you've used all your eggs in one basket, you can't use those drugs again. It does look as if you can go on and use those drugs again. What about the pros and cons of this fixed duration combo? Obvious pro, all tablets, no infusions in hospital. For the patients who prefer a fixed duration, that's obviously a big pro. Of the two here, the mutated, the mutated versus unmutated, we can see that the mutated patients seem to do better with this combination. The unmutated patients is probably looking very similar if they're having fixed duration to having venetoclax and obinutuzumab. Does look like the treatments can be reused later successfully, and some patients with this combination are getting very deep remissions. But in terms of cons, we need to think about the cardiac risks at the start when we're considering selecting these patients. We do see a little bit more in terms of neutropenia and infections when we put ibrutinib and venetoclax together compared with venetoclax and obinutuzumab. I do still have a little bit of a question in my head about all the eggs in one basket question. I think we need to see more patients over the years being retreated with these treatments again in the future. Can't make any comment at all about P53 here, because in terms of the trial data we've got, probably it's only about 20-something patients have been treated in these trials with I+V. No P53 patients were allowed into the GLOW study at all, because they might have been randomized to get chemo, and we know that chemo doesn't treat P53 patients well, so it wouldn't have been fair on the patients. So they were deliberately excluded from the study. So we have very little data about patients with P53 or deletion 17p getting this combo. So we can't comment on its effectiveness in those patients as yet. And I would say, is it needed? Do we need to put those two drugs together for these mutated IGHV patients who we've seen do very well with other treatments already, including the venetoclax obinutuzumab combination? So I'm coming towards the end. What do we have currently? Well, currently we've got everything on the left. We've got acalabrutinib or zanubrutinib continuously. We've got venetoclax and obinutuzumab in fixed duration, and we also have venetoclax and ibrutinib in fixed duration. If you've been treated in the last few years and you're thinking, why wasn't I offered this? We actually only have had access to venetoclax and ibrutinib in this fixed duration combination within the last year or so. It's actually, it's quite a new treatment. What have we got to come in 2026? Well, we're really interested to see the outcomes of acalabrutinib and venetoclax. So, venetoclax, fixed duration, in combination with acalabrutinib, new generation ibrutinib version, so a new updated BTK inhibitor. So we'll see, and that's going to NICE at the minute, so to see whether we get access to that on the NHS. So again, fixed duration, all tablets. Is it the same level of effectiveness as using ibrutinib plus venetoclax? Side effects compared to ibrutinib plus venetoclax. So these are all kind of important things for us to see the longer term sort of data with that. When we're talking about later lines of treatment, so patients who've had treatment before, we take into account all the three things I said before, but I've turned it into a pentagon, because now an important question is, what treatment have you had already? And also, how long were you in remission after the treatment you've had already? So when we're talking about later lines of treatment, if you've had fixed duration venetoclax-based treatment previously, well, you can use fixed duration venetoclax-based treatments again. If it only kept you in remission for 6 months, I probably wouldn't. I'd use something different, because I think that's telling us it's probably not going to get a longer duration of remission the second time round. But if you're one of these people who, 50% were still in remission 5 years later, let's use a venetoclax-based treatment again, because it's clearly worked very well. When we use it in the second and later lines, we use it with rituximab monoclonal antibody rather than obinutuzumab. Equally, if you've had fixed duration venetoclax-based treatment, well, we can change to the other class of drug and use a BTK inhibitor continuously. If you've had previously continuous BTK monotherapy, so you've been on that continuously and now you've relapsed, well, that's telling us we need a change away from BTK inhibitors, so then we would be using a venetoclax-based treatment. If you've used both of those classes of drugs already, then we need something new. if you've relapsed on those treatments already. And then we've got something called idelalisib and rituximab, which we can use. And we've got other things which are going to be coming and available in the future. I've already mentioned briefly pirtobrutinib. That's a kind of next generation updated version of the BTK inhibitors. And the key thing here is we've seen they've been effective in patients who've previously been treated with the acalabrutinib and zanubrutinib BTK inhibitors and relapsed despite those. And that seems to be because the mechanism of action of pirtobrutinib is slightly different, and so it can get round the ways that develop resistance in CLL cells that stop zanubrutinib and acalabrutinib from working. Clinical trials are really important. So I think if patients have had both BCL2 inhibitors, venetoclax-based treatments, and BTK inhibitors, and are now looking for another line of treatment, clinical trials are a really important consideration. I think people often, understandably, are worried, am I being used as a guinea pig? This is a treatment I know nothing about. Do I really want to have this different type of treatment? But actually, all of these drugs we've talked about already, we wouldn't have access to them if they hadn't gone through the clinical trial process and been shown to be effective and safe. So clinical trials actually potentially offer access, early access, to drugs which will turn out to be very, very effective, but which are otherwise unavailable on the NHS. As I've said, all the novel agents that we've discussed today were tested extensively in clinical trials before being licensed, which essentially is saying, they're safe and they're available to use, and then actually being funded within the NHS that we actually have access to them. But we have new drugs in clinical trials currently available in the UK. This is a non-exhaustive list, but you'll notice BTK here. So we've talked about BTK inhibitors. Well, there's a new tablet treatment targeting BTK protein in a different way called BTK degraders. So we have access to that in clinical trials. Sonrotoclax, so the new updated version of venetoclax, so a sort of second generation BCL2 inhibitor. And then there's other drugs in earlier stages of development, ROR1 inhibitors, MALT1 inhibitors. Also, some of the clinical trials are asking crucial questions about some of the treatments we're already using. And I've said over and over again about continuous BTK inhibitors. There's a static trial currently in the UK specifically asking the question, if you've got into a remission on your BTK inhibitor, can we stop it? So stopping it and then following patients up after they've stopped it with the potential to restart it if there's any signs of the CLL becoming active again. So that's, asking the question, do we need to have people on these drugs continuously? So in summary, when we're treating CLL now, it really is very, very different to the chemotherapy-based era of 10 to 15 years ago. A really key thing is that treatments are generally well tolerated. I'm not going to tell you that they come without side effects because it's not true, but they're generally much better tolerated than chemotherapy. And I've sort of highlighted some of the side effects as we've gone along. But important to say, and I hope Liam doesn't mind me mentioning him here, people go through these treatments and continue working very high stress, full-on jobs at the same time. So these people can work alongside some of these treatments. Fixed versus continuous are key questions here in terms of, is that important to you and your lifestyle? Infusions, or please, I don't want to come to the day unit for any infusion, any day unit trips, please, are key questions. As I said, if you only take away one thing, it's that there are no wrong choices. There are no absolute right or wrong. All of these treatments are good options. If there was a clear answer which one was better, we could just stand here and tell you, but we don't actually know that because all of these are good options and there's no absolute right or wrong answer. We might lean towards fixed duration treatments such as venetoclax and obinutuzumab for mutated IGHV, and we might lean towards continuous BTKI if we see a high risk feature like unmutated IGHV or P53, but it is not an absolute. And in 1 to 3 years' time, if we're back in Newcastle having this talk again, we'll almost certainly be talking about some newer, different treatment options that we have available that are currently in development at the minute. Thank you very much.
Other than whether something is approved by NICE, does funding come into your decision-making with what treatment to give people? Because I can imagine a continuous treatment presumably is a much longer cost commitment.
Simple answer is no.
Good.
So the funding, the money question is completely down to what's funded by NICE. Beyond that, if we've got available to us, off we go.
If you're on a continuous treatment and you have another health issue which needs to be looked at and it's necessary to come off that continuous treatment, is there a sweet spot in the time window that you have so that your CLL doesn't become more serious during that period of off medication?
That's a good question. So we know that in some settings, if you're on a BTK inhibitor and you stop it, sometimes the CLL can almost have a flare that then when you restart the BTK inhibitor, that seems to come back under control.
Okay.
So I guess if somebody was just about to start a BTK inhibitor and it turned out that they needed to have some procedure done, and because of the bleeding risk, one of the side effects with BTK inhibitors, I would ask the patient, I would say to the patient, you need to stop your BTK inhibitor usually for about 5 to 7 days before a procedure. Then I would probably say to them, we're about to start the BTK inhibitor, go and get that other procedure done first, rather than us starting the BTK inhibitor and 3 weeks later having to stop it for a week. However, if you're on a BTK inhibitor and you need to have a procedure done, we just stop it. The number of times that we run into problems with a CLL flare when we stop the BTK inhibitor, I would say is it definitely happens, but it's uncommon. I think it's more likely to happen if you've only just started, or if actually your BTK inhibitor is its effectiveness is starting to run out. But actually, we very safely, very commonly, when somebody's been on a BTK inhibitor for a period of time and their disease is under good control, it's something we have to do quite frequently is they stop it for a week to go and have what other operation they need doing.
If a treatment is approved by NICE, is it available in all nations, devolved nations?
Good question. So no, so Scotland have their own, I'm trying to remember what exactly
SMC.
Yeah, exactly, the Scottish Medicines Consortium, thank you. So they have their own sort of funding body. But typically, the SMC do seem to sort of follow the path of NICE. So typically, if something's been approved by NICE, it may not instantaneously be available in Scotland, but typically SMC tend to follow the same sort of funding decisions. So usually the treatments then shortly after become available in Scotland as well. But NICE applies to Wales and Northern Ireland, so we're all in the same boat there.
I've had FCR with 9 years remission, then venetoclax 2-year treatment plan, which only gave 2 years remission. I'm currently on acalabrutinib 1 year in and currently doing well. Would I be able to go back to venetoclax and acalabrutinib combination when and if needed? So
I'm going to hear that question as, am I able to go back to acalabrutinib and venetoclax combination? So the answer to that is, at this moment, no. So first of all, acalabrutinib and venetoclax, we don't currently in the UK have access to. It is not funded by NICE in the UK in any line of treatment for CLL. It is licensed, so it is safe and available to use, but it's not currently funded by NICE. We're waiting for the outcome of that decision, which probably will be in spring next year. As and when it is decided by NICE whether it is available, acalabrutinib and venetoclax in fixed duration combination, we are anticipating it will only be approved in that setting in treatment-naive patients, so patients who've never had treatment before. So this would not apply to this patient who's had other lines of treatment. So they would not be able to access A plus V on the NHS in combination. And actually it's not licensed in that relapsed refractory setting either, so they wouldn't be able to access it. However, using a venetoclax-based treatment again would be an option, potentially, or as we've said, we have this other drug, idelalisib, which is used much less commonly these days, but it sort of got thrown out with the bathwater because it came with some infection-related side effects. So it doesn't get used often, but it is an option for patients who've been through BTK inhibitors and BCL2 inhibitors, and I would be absolutely also thinking about clinical studies. Your patient at the minute remains on acalabrutinib, is doing well. We don't know as and when they need something else. What else is going to be available from the list we've got here, which are, other drugs that are in the pipeline.
With the acalabrutinib, the side effects, are they instant or?
Yeah, good question. So no, the answer, so acalabrutinib, in terms of side effects, probably, if you're going to get side effects from it, the majority of them tend to be within the first year, with the exception of knowing that hypertension and probably also atrial fibrillation, but definitely hypertension, high blood pressure, their chances are the same for as long as you've been on it. So if you've been on it for 5 years, you've got just as much chance of still going on to develop high blood pressure as you did in the first year. But typically, the other side effects tend to be most concentrated within the first year. Specifically with acalabrutinib compared to zanubrutinib or ibrutinib, there's 2 other side effects which I didn't mention, both of which tend to be transient, so they tend to just happen for a few months and then stop, and that's headache and diarrhea. So headaches can happen in the first few months and then they seem to wear off. They seem to be caffeine responsive, so a cup of coffee or a can of Coke seem to sort them out. And then diarrhea or upset tummy. But again, they tend to be transient, so it seems to just be within the first few months and then wear off. And we say about a third of patients will get those side effects in the first few months of treatment.
Mine was just about immune systems, really. I think we all often say, oh, I've got a low immune system. And I never really knew what it meant. I just thought, because I've had chemotherapy, that I was a bit more vulnerable. But recently I've learned a bit more about IgG and IgA and all of those. Mine are really low. But do they rally? Because they seem not to be, hence not being allowed to go back to work.
Yeah, so two bits to that. The first thing is, going back to my hematopoiesis diagram right at the start. So because CLL cells come from lymphocytes, and one of lymphocytes' jobs as they mature through the lymph node is to make antibodies. Antibodies is just another word for immunoglobulins, IgG, which is what you just mentioned. They're just little proteins, antibodies, which help fight infections. They're part of the whole immune system that help fight infections. So if you've got CLL, even if you've never had treatment, some, not all, patients with CLL will have low immunoglobulin levels already because their CLL is affecting their lymphocyte B cells whose job it is to make antibody proteins. So some patients with CLL already have low immunoglobulin levels. To add to that, we know that specifically obinutuzumab and rituximab are both treatments who the way they act is sort of targeting the CLL B lymphocytes, but it does mean that as you come out of the treatment, your B lymphocyte level, obviously the CLL ones, but also the healthy B lymphocytes are at a much lower level. So if those are the cells you need to make antibody immunoglobulin proteins, well, you can't make as many anymore because you haven't got as many of those healthy B cells. So that's a bit of a double whammy. Now, over time, we think that there is an improvement and a sort of recovery in the B lymphocytes and the healthy B lymphocytes as time passes, but there is that double whammy that it's both CLL and treatment. So for some patients, that level may remain low. For other patients, it will recover over a period of time. If people are getting recurrent infections and we can see that their antibody levels are low, we can think about actually giving them top-ups of IgG immunoglobulin to sort of recover the level as one of the sort of treatment strategies.
Okay, thank you very much once again, Dr. Helen Marr. Thank you.